Okay, Dr. Quentin, are you there?
I just arrived. Sorry for the
Thank you.
little glitch. I was struggling to find the code to access the meeting, but I
Yeah.
was able to make it.
I,
Sorry for being a bit late.
no, no, I apologize because I didn't send you the code, but with the new link that I sent you, I think it was solved.
Yeah, yeah. That's
Okay.
all fine. What matters is that I was able to make it all in all. Okay.
Okay. Thank you. Welcome, Dr. Quentin. And well, now that all the speakers have connected, we are going to start. So this will be recorded also, and then will be shared in the YouTube channel of ICOH Peru. So, well, I'm going to give admission to the other participants that are still connecting. And welcome to all of you to the 13th webinar, Education and Training in Occupational Health and Safety, Global Perspective, Barriers and Challenges. This academic event has been co-organized with the support of the Scientific Committee on Education and Training in Occupational Health from ICOH and the ICOH National Secretary of Peru. Um, well, as Martin Luther King Jr. said, the function of education is to teach one to think intensively and to think critically. Intelligence plus character, that is the goal of true education. And based on our experience in different sectors, including government, academia, or private sector, we know how crucial the education is not only for workers to build and to sustain a prevention culture, but also for each one of us as occupational health and safety professionals, including physicians, nurses, engineers, psychologists, and others. That is why we were motivated to co-organize with this webinar, and we have prepared two sections. And the first part, we will have five great speakers from different countries around the world. And in the second part, we will have a roundtable session with early career professionals who has been working very hard in different fields of occupational health and safety. So for starting, oh, as I told you, we have the support from the ICOH Scientific Committee of Education and Training in Occupational Health, which chair is one of our speakers, Dr. Rajiv, and I will introduce you very soon. So now we're going to introduce you to our first speaker, Dr. Quentin Durand Moreau, who is an associate professor in the Division of Preventive Medicine and Occupational Medicine Residency Program, director at the University of Alberta, Canada, since 2019. Prior to that, he worked in France for 5 years after completing his residency training and was appointed as the director of the Occupational Disease Center of Brest University Hospital. He currently practices as an occupational medicine specialist at the Occupational Environmental Medicine Clinic, KE Edmonton Clinic. He is a board member of the International Commission on Occupational Health for this triennium until 2027, a member of the Council on Occupational and Environmental Medicine Science of the American College of Occupational and Environmental Medicine, ACOM, and a member of the Scientific Council of the French Society for Occupational Health. His topics of interest and research include work-related mental health issues, occupational cancer, COVID work-related issues, and medical education. He obtained a master's degree in education from the University of Montreal in 2023. So welcome, Dr. Quentin. It's a pleasure to have you as one of our speakers and to share this night well, this journey with us. Um, I will make you host so you can share your presentation.
So while you're doing this, I'd like to thank you, Dr. Mirachu, for the organization of this webinar. Peru has always been an extremely active country for ICO, and I remember some statistics on the number of members by country, but I kind of recall that Peru is maybe in the top 5 of the countries with the highest numbers of ICO members. So that's always great to see the support of Peruvian colleagues to ICO, and I'm delighted to be with you tonight to talk
Thank,
about a topic that I like, medical education. I hope that you can see my slides. Should work normally.
yes,
Yeah.
it
Yeah. Okay.
works.
Beautiful.
Thank you.
So, and I understand that I have 20 minutes, so I'm going to put the chronometer to respect my time. And I'm going to get started by recognizing that I'm currently located on Treaty 6 territory. So Canada is a place where colonization has kind of shaped the country and the borders of the provinces and territories we do have currently. But before that, there were for many years before colonization, indigenous people in Canada, and we need to recognize how they shaped history and how we are lucky to be on these lands. So the University of Alberta is located on Treaty 6 territory, which is this kind of green dot across Alberta and Saskatchewan here. And we do have many indigenous groups, including Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit as well, and many others whose histories, languages, and cultures continue to influence our vibrant community. My link of interest for this presentation, I can answer any questions you might have. I'm paid by the University of Alberta as an employee, and I do receive professional income by our provincial healthcare provider, Alberta Health Services. And I am a member of the Royal College Occupational Medicine Subspecialty Committee as a member, and it is an unpaid role. And I'm also, as Dr. Marashu has mentioned, a board member of ICO, and similarly, it's an unpaid role. So I am like the title of my presentation might not be what's gonna keep you awake at this time, but I'm going to try to make it quite interesting. And I think it might be interesting to you, especially if you've yourself experienced occupational medicine training, because it's gonna be a way for you to compare what's your own experience as an occupational medicine specialist with what occupational medicine training is in Canada and what it is going to become in the next couple of years. But before I explain you this, I'm going to have to go through a couple of definitions and concepts that we are working with in Canada and that are reshaping the way we envision residency training in our country. And this is competence by design. So what is this thing? So the typical approach, a traditional approach to residency education for many years was what we call the time-based approach. You take a residence, you put this residence for so many weeks in such and such rotations, and voila, you think that this resident is going to be skilled in whatever rotation they have been through. So this is this time-based approach where the requirements are usually defined in terms of so many weeks in such and such rotations, such as 4 weeks of toxicology, 4 weeks of occupational hygiene, and so on and so forth. This is an outdated model because we're not really assessing what the residence does. We are assuming that they are competent because they've attended so many rotations. A new system is what we call now the competency-based medical education, or CBME, which is an outcomes-based approach, where we're going to look at what the resident can do and what they can't do as well. We're going to use competencies or observable abilities or skills. And we want to ensure that all learners achieve the desired patient-centered outcomes during their training. But there is a problem with this. It's that a resident can take maybe 10 years to fulfill all of the requirements, and there is no funding provided by the Ministry of Health to pay a resident for so many years. So we needed to find something in the middle, which is what we came with, which is the CBD. It's not absolutely not referring to anything related to cannabis. It is competence by design, and we do use this abbreviation of CBD. And it may make fun discussions with colleagues. Anyway, this is a Canadian hybrid CBME model combining a time-based approach with an outcome-based approach. So we put a limit, a time limit as to how long a resident can take to acquire all of the skills they need to acquire. So that's kind of
Wow.
the shift that we are going through. So we have different elements within the CBD program. We have to define the framework, the different stages of training and learning objectives, how we assess this in practice, and how a committee decides on resident promotion. So I will go through all of those steps. First, we need to define different stages of training. Those are called transition to discipline, foundations of discipline, core of discipline, and transition to practice. And they correspond to periods within the residency training of several months to several years that delineate where the resident is and what the expectations can be. A resident that's in transition to practice should have the skills closer to someone that's in independent practice, whereas a resident that's in transition to discipline is really a new one, and they need much more guidance to be supported during their training. Then we are going to assess those residents through learning objectives, and what the important element here is what we call EPAs, entrustable professional activities. We are going to have maybe up to 30 to 40 EPAs during the entire residency program, where we're going to look at activities that the resident can complete. So an example of an EPA in occupational medicine could be, for instance, taking an occupational history. This is something that I can observe. This is something that I can assess. And at some point, the program could decide that, yes, this resident is competent in taking an occupational history. And you do this for all of the skills that are required for an occupational medicine specialist. So those stages of training and all of these learning objectives are designed during workshops, and we are currently having those workshops at the Royal College. And it's basically a bunch of occupational medicine specialists gathered all together 3 times for 3 days in Ottawa, the Royal College headquarters. They usually provide good snacks. And we work on drafting those learning objectives and all of the accompanying documents, the list of competencies, all of what we need to get to explain to each resident and each program what they need to go through. So we benefit from the support of the Royal College to go through this transition. Then once we have decided on all of these EPAs and documents, and they are going to be released and made public, we will use them and implement this in the program. And each resident is going to have a kind of a book or portfolio, virtual portfolio, where they're going to keep track of all of the EPAs that they have completed. The performance is going to be documented. And to do that, we're going to use IT tools at the level of each university to monitor this. This will allow us to give closer resident feedback, because in a rotation of 4 weeks, usually there is one final assessment. In the new system, where we have EPAs, we expect residents to complete 2 EPAs per week. So there is going to be much more assessment and at an increased frequency. So supervisors are going to give much more feedback to the residents. And then with all of this documentation in the system, a competence committee made of faculty members is going to review everything for all residents and decide whether or not they have achieved the requirements and be promoted to the next stages of training. But the caveat is that we will need more committee time. It basically duplicates the committee time we require from our faculty members. So these transitions are occurring in Canada since 2017, and every single residency program is going to be in this model. And actually, occupational medicine is at the end of the cohort. So what's the situation for occupational medicine in Canada right now? And I will explain what it may look like in this new CBD system. So currently in Canada, there are only 3 programs, which means that there are only 3 places, 3 cities in the country where a resident can get specialty training in occupational medicine. So there's here at the University of Alberta in Edmonton, in Alberta, My colleague Vince Spelchuk is the program director for the University of Toronto in Ontario. And my colleague Louis Patry is the program director for the Université de Montréal program, which is the only one in French. So that's not a lot of programs. A number of specialties are present in all 18 faculties of medicine across the country, but there's only 3 programs. So residents who want to do OCMED have to move to one of these cities. And we usually join forces, we work all together, and we have a national academic half-day system because we're so few, but we decided to take this as an advantage and join forces to offer a platform for all of the experts nationally and sometimes internationally to participate in the delivery of teaching sessions for our residents. So if I take the perspective of a learner going through medical school and onwards, so medical school in Canada is usually a 4-year program, usually after an undergraduate degree. So a student is going to complete high school. They are not going to enter medical school right after med school, right after high school, like I did in France. We enter medical school immediately after high school. So here in Canada, they need to complete what we call an undergraduate degree, a Bachelor of Sciences, for instance. And then they go through selection and they are admitted in med school, usually for 4 years. In some schools, it may be 3 years. At the end of the 4th year, they have to decide what kind of residency training they want to go through. And we have in Canada a matching system where residents are going to list by order of preference the programs they want to go. They are going to be offered potentially interviews. And after interviews, the programs are going to rank the applicants to their programs by order of preference. Then it goes through a system. The system is called CARMS, Canadian Residency Matching System, CARMS. This is what CARMS stands for. And then we have the list of residents per program, and the residents know where they are going to go. So we have CARMS R1 programs. Those programs are the primary entry specialties. So there are many, many primary entry specialties. So general surgery, it can be core internal medicine, as you see here, or it can be public health. Sorry, there's some.
Sorry.
Yeah, okay, so that's all good. It's under control. So yeah, as I said, there are primary entry specialties. Occupational medicine is not a primary entry specialty. It is a subspecialty. So it means that the resident needs to fulfill a primary entry specialty before considering an OCMED training. So to access an OCMED training in Canada, residents have 2 options and only 2 options. They can go either through a core internal medicine residency program of 3 years or a 5-year residency program in public health and preventive medicine, at the end of which they go through another round of CARMS. This is a different subset of CARMS where they can select the subspecialty they want to do. So for core internal medicine residents, they have the choice between many subspecialties, including critical care, cardiology, respirology, and all of those specialties. OCMED is within this group of subspecialties. And public health and preventive medicine residents can also access occupational medicine as a subspecialty. So this is the system we currently have. The residents that are in the programs up until today have been through this. We have multiple challenges with this system. First, motivated med school students have to go through a long journey before eventually starting an OCMED residency program. And they have all the time to be contaminated by all of the other specialties that are going to steal the good residents and deter them from going to OCMED because there are so little requirements in core internal medicine and public health and preventive medicine, and residents are mostly not exposed to occupational medicine. They are not exposed in med school most of the times. They have very little exposure in core internal medicine or PHPM as well. The CIM program is very competitive. So to go through this route, you need to be very, very good. And that's quite difficult to access through this route. So if you want to do OCMED, the public health and preventive medicine route may be less competitive, but you see that it makes an awfully long residency program, up to 6 or 7 years. And all in all, we have very, very low numbers. So more recently, the Royal College has conducted an in-depth review of the subspecialty, which corresponded to a moment where they looked at the challenges we've been through. So we identified a number of concerns, and especially concerns with the sustainability of the discipline, given the so little numbers that we have in the system. And long story short, the Royal College has decided after this in-depth review that the specialty, occupational medicine, will be better suited for a primary entry route rather than the current subspecialty model. So it's been decided to move occupational medicine from the R4 match back to the R1 match, which is a huge change for us. And as we've not completed our CBD transition that we would have to do in any case, it's been decided to do both simultaneously. We are going to move back to a primary entry residency program and work on our CBD documents all together. We are the single program with this double transition within the maybe 60 different programs that have transitioned. We're the only one with this double transition. So in the meantime, as we knew that this transition to CBD was coming, and as our current standards of training are very old, they are from 2013, outdated, there's virtually nothing about environmental medicine, for instance, I decided to take the lead on a national working group to get started thinking of what we need to have in this new program. So we've issued a document and we communicated on this at the last ICOH conference. And this document has allowed us to classify skills requirements that we would like to have for residents within 8 sections that are on the screen. Anything from work and employment to hazards and risk management. We have a section on environmental medicine now, and also tools and methods in occupational medicine. And this document is now used for our workshops to design what's going to be the final EPAs and requirements. We also conducted an environmental scan specifically on the question of psychosocial risks. I'm going to talk about this more in depth at an upcoming ICOH conference, the ICOH WOPS conference on psychosocial factors. That's going to be in Ho Chi Minh City in December 2025. This is a good opportunity for me as the chair of this conference to invite you to join this ICOH WOPS conference. But for those who are unable to join, there will be a publication, and it's currently under peer review in Occupational Medicine London. So to finish my presentation, I'm going to give you what it is supposed to look like for the future, what I can share at the moment. Nothing is solidified today. As I told you, we are currently working at the Royal College, and on the screen you see a picture of the people involved in a working group at our last CBD meeting in April. The next one is going to be in November, but we also have in between work. We reviewed some documents. We had a bunch of documents to review earlier this month. We expect the standards to be released in 2026. And it's going to take a bit of time because, as you know, Canada is a bilingual country. So the standards can only be made public once they are also translated into the French as well, because our colleagues in Montreal need to have French documents as well. So all of this is going to take some time, but we expect that the first cohort going into the new model is going to get started in July of 2027, which is going to come sooner than later. So this is what it may look like. This is not solidified, as I tell you, but we would expect still med school. This is outside of the discussion. The residents are going to pick up occupational medicine at CARMS R1, the match that occurs right at the end of med school. We expect the new program to be a 5-year program, even though it's not yet confirmed. Could be 4 years, but given all of whatever we ask residents to know, we think that it's going to end up on a 5-year program. The thing is that we are still uncertain as to how the residents currently in core internal medicine and public health and preventive medicine will still have a way to join occupational medicine, because we can't have both systems functioning. We're gonna, in 2027, we stop the other system. We are implementing this. We can't keep both systems alive for many different reasons, exams reason, Royal College requirement, we can't. But if we have a learner currently in PHPM and willing to do occupational medicine, say 3 years from now, they may become ineligible if we don't think about other routes of entry. So this is something we have to finalize. So all in all, this is my presentation. We are, as you now understand, in the middle of a profound curriculum change in Canada to train our occupational medicine residents. We are hopeful that it may attract more residents, and especially it might be easier for us to get international medical graduates. I get an awful lot of requests from international learners, not so much Canadian ones, but a lot of people elsewhere willing to get training in Canada. With this system, we may have ways to offer them a real residency training with the potential for practice in Canada, which we can't at the moment. But we have a number of challenges. Occupational medicine, whether we like it or not, is by definition an unattractive discipline in almost every country in the world. Everyone that I'm talking with internationally, it is unattractive, especially when we consider the residency level as an entry level. But it is increasingly attractive as the career goes. And there are a lot of learners that go through re-entry routes that are incredibly popular, for instance, in France. It allowed them to double the number of learners. We will have challenges in double certification. We'll have challenges in terms of workload and residence codes in between the two systems. And we don't know what's the effect of this change. And I'm stopping now because I reached my time. Thank you for your kind attention.
Thank you, Dr. Quentin, for such a wonderful presentation and for sharing very detailed information about how the residency program in Canada works and which is the perspective for the future. I think it's very valuable for us, and we can take some information even for think and redesign programs here in Latin America. There is some attendees that are in the waiting room. Please, could you admit them, or maybe I can be there.
I just admitted everyone. I
Oh,
said
thank you.
I've seen this. I admitted everyone.
Thank you, thank you. They are with a lot of expectations to make some questions. So we would like to ask people, the attendees to make some questions, and if there is someone that can make questions in Spanish, we can help you with the translation. Si hay participantes que quisieran hacer preguntas en español, les podemos ayudar también con la traducción para comunicarse con el doctor Durán Moreau.
Ou en français, si vous voulez des questions en français, je peux répondre en français.
O en francés también, por favor.
Norville, buenas noches.
¿Cómo estás, Álvaro? Bienvenido.
Bien, una pregunta. ¿Cuál es el interés de los estudiantes de medicina de estudiar medicina ocupacional versus las otras especialidades? ¿Cuál es la experiencia de ellos?
Okay, Dr. Quentin, I think you mentioned that in the last slide, but how much interest from students in the undergraduate programs from medicine school, from the faculty, they show for being occupational medicine and environmental physicians? Or maybe it's not so much attractive for them.
Yeah, so that's a challenge that we're going to have because now our pool of recruitment is moving from current residents to people that are currently in med school, so medical students. The problem is that we are lacking visibility in medical schools. And even I told you that there are only 3 programs, but there are 18 and like 19 Faculty of Medicine has opened this year, and the 20th one is going to open in the near future close to Vancouver. So basically 20 med schools, 3 programs, and even in my own university, it is a challenge to put a foot in medical education at the med school level, even to implement an elective or a module. I know, like I see Manny Berenger from the US, and I'm always thinking of the work Marion Cloran has completed at the University of Maryland, is putting up a nice elective, and she does a lot of stuff. And I'm kind of jealous to do this because it's super attractive for students, but we're not allowed to do that because there are considerations that take precedence. There are teaching sessions that take precedence, and now there are a lot of concerns with regards to student burnout. And trying to remove stuff from medical education rather than adding stuff. So that's why I think it's going to be challenging for us in terms of visibility and how desirable we might be. And also organizing stuff such as industry tours and site visits is raising something that's maybe more concerned with us in our highly protective environment rather than what I had in experience in France, is insurance matters. How you can bring med students on an industry site. I'm going to think that it might not be possible for insurance purposes to bring a student visiting an industry site, and this may bring the wow effect that brings people into our specialty. So challenges still for us. I don't know if it addresses the question.
I think
Yeah, thank you for the answer. Yeah.
Yeah, thank you, Dr. Quentin. Is there anyone in the room that would like to make a question in English, French, or Spanish, please?
Yeah, Dr. Quentin, good evening.
Hello.
Your presentation was very enlightening, and there's a huge scope for interaction and collaboration at the international level to develop the occupancy-based curriculum that you are evolving. And I hope with this, a new journey will start. I just wanted to understand that this process, how it has been evolving in the United States of America versus Canada. How much is the contribution that you've taken from United States of America in terms of competency-based curriculum, and how is your assessment of competency-based curriculum in occupational medicine in United States? Thank you.
Thank you, Dr. Kumar Jain, for your question. I'm not sure I get your question. You're asking about how it is in the United States, or like, because I'm not practicing in the United States, so we have people in the call from the US that may be better positioned to say whether or not they are in a competence-based model in the US. But I'm just able to speak for Canada. I do believe that in France, they are implementing the spirit of competence-based medical education with the stages of training. They now have stages of training. I'm not sure they have all of the paraphernalia of EPAs and competence committee and all of this that requires an awful lot of work. Sorry, I'm not sure I'm best positioned to ask to respond to your question, but I think it's a good question.
Yeah, that's fine. I believe that. Thank you.
Thank you. I was wondering, Dr. Quentin, well, I got really interested about how the perspective in Canada is that a specialty of occupational medicine will last 5 years, will take 5 years to get the residency program finished. So with that perspective, these 5 years would include rotations inside hospital, qualifying, assessing the disease that is originated in the job, but also some rotations inside companies, or the main rotations will be inside hospitals.
Yeah, so that's a great question. So as I told you, it's going to be divided in stage of training. So at the beginning, we have transition to discipline, and then we will have foundations. The foundation stage, we expect this to be really the bulk of what we called now in the past basic clinical training. So we expect the residents to rotate in respirology. We expect them to be competent in respiratory conditions, dermatology, PM&R, sports medicine, psychiatry and addiction medicine, all family medicine as well. So all of the basic specialties to kind of make sure that they have the skills to practice as a general physician, to have basic medical knowledge. And then later in their training, they're going to move to the core of discipline. This is where they're going to have the industry-based rotations. This is where they're going to rotate with the Workers' Compensation Board. This is where they're going to go with the Ministry of Labor. So this is a little later in the training, at a time where we're sure that they have the clinical skills and they would have enough theoretical knowledge to take maximal output of those rotations in practice.
Okay, thank you. So is there anyone else in the room that would like to make questions to Dr. Quentin? Okay. Well, thank you, Doctor, for sharing this great presentation and experiences from Canada, but also we have many lessons to take that we can apply in our context and reality to improve the education programs for occupational medicine physicians. So we would like to invite you to stay with us and to share during the rest of the presentations. It will be an honor for us. So I will claim the host and now we'll present our next speaker. So thank you, Dr. Duran Moreau. It's been a great presentation, and I'm going to present our next speaker. So our next speaker will focus on occupational health nursing education. It's Dr. Penny Orton, which is a nurse educator who holds a PhD from the University of KwaZulu-Natal, South Africa. Penny is currently pursuing many of her special interests, which spans education and research in academia and clinical occupational health practice. Penny has an appointment at Durban University of Technology as an honorary research fellow in the Faculty of Health Science, with responsibilities for postgraduate research supervision, mentoring, and coaching academics in the scholarship of teaching and learning and research supervision. Penny continues to consult in occupational health and does some clinical occupational health work, most recently related to a large chemical farm in Durban, South Africa. Penny has over 16 years of clinical occupational health experience, as well as 20 years of academic occupational health experience. Her experience has spanned many industries, including Nampak and South Africa breweries, and she worked for herself doing a variety of enterprises. So, welcome, Dr. Penny. It's a pleasure to have you here. I'm going to give you the option to share. Oh, let me try this option that participants can share their screen.
Right. Hello, and thank you very much, Norval. While I, if you don't mind, I'm going to keep my camera off because
Okay.
I've noticed when Dr. Quinton was presenting, I had very unstable internet, and I'm
No, never mind.
away.
Never mind. I'm just
So
looking
I'll
for
just.
I'm just looking for the option. Oh, sorry. You were telling me.
No, I was just going to say, so for that reason, if you don't mind, I'll just keep my video off.
Okay. I was looking for the option to make that everyone can share their screen, but I just don't find it. So I can help with the meeting participants. Well, I will make you host. I think it will be the easier way.
Yeah.
Yeah, I will make you host so you can share.
Okay. Yeah.
So now you're the host and you can share your presentation, please. Welcome, Dr. Penny.
Good. Thank you very much. And thank you very much, Dr. Norval, for inviting me to present on occupational health nursing, the nursing education from the South African perspective. As you've said, I'm an honorary Research Fellow at Durban University of Technology. So just a little background to nursing training in South Africa. We have 3 categories of nurse: a professional nurse, which is the 4-year bachelor's degree, a general nurse who undergoes 3-year diploma, and then we have an auxiliary nurse, which is a 1-year higher certificate qualification. The training of nurses in South Africa, along with every single educational training qualification, has recently, in the last 10 years, undergone changes. So in terms of those sort of older nurses who have been around a long time, they'll have many different variations of training that they've undergone. But now we have a national qualification framework, and every single qualification in South Africa is pinned onto this national qualification framework, including nursing training. All nursing training in South Africa is in higher education, and it's controlled very much by the South African Nursing Council, both education and practice. So as much as the universities are autonomous, we still have to make sure that we comply with the council requirements for the nursing training. So as mentioned, we have a national qualification framework, and nursing training falls under the higher education qualification sub-framework, which is from an NQF level 5, as you can see, the higher certificate, which is the auxiliary nurse, all the way up to doctoral qualifications at an NQF level 10. Now, the occupational health nursing is a specialist program in South Africa for postgraduate specialists, and this is pitched at an NQF level 8. So the 4-year Bachelor of Nursing degree is at an NQF level 8, and the postgraduate diploma is also at an NQF level 8. If you're a general nurse and you've done a 3-year diploma, that would be at an NQF level 6. You then would have to do an NQF level 7 advanced diploma in order to access a specialist occupational health nursing qualification at a postgraduate level. So a postgraduate diploma level. So in South Africa, in order to do any of the 16 nursing specialities, you have to have a qualification in midwifery as well. So the 3-year diploma in nursing is just general nursing, and then the advanced diploma is a midwifery speciality. Well, it's not really a speciality, it's basic midwifery, but over 1 year. And then only can you access occupational health nursing or any of the specialities at a postgraduate diploma. There's some controversy around this in our country, mainly because particularly male nurses are not particularly interested in doing midwifery. However, if they want to access any speciality right now, as we currently stand, the only advanced diploma in nursing is midwifery. And so there is talk about maybe bringing in mental health and it's an advanced diploma to give access to postgraduate diplomas for those that don't have midwifery or don't want to do midwifery. So occupational health nursing in South Africa is a specialist qualification, and as I mentioned earlier, it's one of 16 nursing specialities. It's an advanced nurse practitioner role. Although in our legislation, the advanced nurse practitioner is really, by definition, that practitioner needs to have a master's degree, whereas it's more, we refer to the postgraduate diploma level specialities as specialist nurse practitioners, but it is a more advanced practitioner role. It's very much driven by the reasons for having the specialist is driven by the Occupational Health and Safety Act, which requires an occupational health nurse practitioner who is got a postgraduate qualification in occupational health nursing and is registered with the South African Nursing Council as an occupational health nurse specialist in order to carry out certain activities under the Occupational Health and Safety Act. For example, an occupational health nurse specialist can do the health examinations on chemical workers, or they do audiometry, spirometry, those kinds of activities. And so certain regulations under the Occupational Health and Safety Act require either an occupational medicine practitioner or an occupational health nurse specialist to do the health examinations and the occupational health examinations for those particular employees. There's also a South African Nursing Council position paper, which positions that no patients, or in our case employees, may be nursed in a specialist unit by nurses who are not specialists. So yes, this is more, very much geared towards, for example, intensive care and theatre, operating theatres, casualty trauma units, etc. But it's also gives the occupational health nurse specialists something to use as well, that if, it's cheaper, obviously, for enterprises to employ non-occupational health specialists in their organizations. But in terms of the Occupational Health and Safety Act and in terms of the South African Nursing Council position paper, it's incumbent on employers to employ professional specialist occupational health nurse practitioners. Again, as I've mentioned earlier, this is in higher education. So in order to be in higher education, or whether it's a previously what we understood as a college of nursing that offered diploma programs, or the universities, they all have to be accredited under the Council of Higher Education. And so even, as you see, the level 5 one-year program falls into higher education. And that has a whole lot of ramifications around the quality of the organization that's offering the programs. So there's a dire shortage of nurses in South Africa. It's not a very attractive profession. Obviously, with all the different professions that are now available to young people, nursing's not really the most attractive. Really things like the hours, the type of work, things, we have a very high burden of HIV in South Africa, and obviously the COVID epidemic or pandemic didn't help things. And so, why would you want to go and nurse a highly infectious person through the night when you can, and for little reward, financial reward, where you could perhaps have, a nice IT job that gives you regular hours and good salary, etc. So we do struggle to get suitable people into nursing, and then obviously with 16 nursing specialities, just as Dr. Quinton mentioned, in attracting medicine practitioners, we also battle to attract nurses into the specialist occupational health nursing. Two paths to the specialist occupational health nursing is either through the 3-year diploma in general nursing at NQF level 6. Then they have to do a 1-year advanced diploma in midwifery at NQF level 7. And only then can they access a 1-year postgraduate diploma in occupational health nursing. This 1-year postgraduate diploma is most commonly done over 2 years part-time, because generally our students coming into the programs are all working and they can't afford to not work. So they have to do the program part-time. And the reason for these two pathways is the articulation. You cannot jump from an NQF level 6 program into an NQF level 8 program. you've got to, follow the pathway of not skipping out a level. Otherwise, you can do the 4-year bachelor's degree in nursing and midwifery. So the 4-year bachelor's degree includes midwifery in the program, and then you can access straight away a 1-year postgraduate diploma in occupational health nursing. An outline of a postgraduate diploma in occupational health nursing in South Africa. It's 120 credits, which is 1,200 notional hours. It's obviously SANC accredited, and sorry, I just want to. The SANC accredited or the South African Nursing Council accredited competencies. There's plus or minus 8 to 10 modules, depending on the university, how you would like to structure it. It's a combination of theory and practical, and with the new regulations around all nursing education in South Africa, whether it's at undergraduate or postgraduate level, they need to have about 60% of the credits needs to be in practical areas. What we found in South Africa, the quality of nursing has deteriorated over the years, and there's a thought that there's too much theory and not enough practical nowadays, and as a result, you've got this deterioration in the quality of nursing. So they're trying to rectify that by increasing the credits for that are required for the practical components. I think, like with Dr. Quinton was mentioning with medicine, this overload of requirements means that it's quite a juggling act where, we keep saying, oh yeah, but this is, necessary theoretical knowledge, and this is necessary, and this is necessary, and we're making our programs bigger and bigger and more intense, and expecting students to do more and more. So it is this juggling act of how can we merge these two but still meet the requirements of our boards. So the PGDIP has obviously the occupational health discipline knowledge. It's got a strong health promotion component in it, and then we do management, and there's research modules as well. The clinical practical includes audiometry and spirometry, and these are the two clinical skills that kind of are very unique to occupational health nursing. None of the other nursing specialities do audiometry and spirometry. Health assessment, obviously, because in terms of the Occupational Health and Safety Act and some of the regulations, for example, ergonomics regulations and so on, the occupational health nurse specialists can do the health assessment. And then the experiential hours in a clinical occupational health setting. And that, on average, is about 160 hours that students have to do in enterprises. They will do a small component of that, might be some emergency care, a few hours in a trauma unit or so, just to refresh their trauma skills. But most of that would be done in some sort of industry. It has to be accredited with the South African Nursing Council. So the clinics that the students go to need to be accredited with Council. They need to be supervised by an occupational health nurse mentor, and obviously the strict record keeping, which gets audited by the South African Nursing Council from time to time. So the South African Nursing Council has lists competencies for the various specialities. And all these specialities have 5 domains, various subdomains, core competencies, and specific competencies. And these are split across these 5 domains. So there's the professional, ethical, and legal practice, clinical practice, care provision, and management. And that's where obviously all the occupational health nursing, clinical nursing would come into it. the quality of practice, management and leadership, and research. And at a postgraduate level, this research is very much about evidence translation into practice. We expect the students to already have done basic research and have developed those basic competencies during their degree or diplomas, and that when they get to this postgraduate level, we expect them to start looking at translating evidence into practice. So more evidence translation type of research. And an example of this would be just a little screenshot from, tiny piece in the professional, ethical, and legal practice domain. You have a subdomain core competency of professional practice, and then there's the specific competencies listed under that. Interestingly, the issue of working in a team of professionals, which leads us into the interprofessional education, which is one of the challenges that we have, and I'll talk a little about that. So some of the challenges that we face in South Africa, and I don't think these are unique to South Africa, I think that we can probably all identify with them. Obviously, we have an aging occupational health nurse workforce. In South Africa, 50% of nurses, just generally nurses across the board, are over the age of 50, and I think 40% are over the age of, or heading towards, very close to 60 or just over 60. And we have a enforced retirement age in South Africa, depending on the organization, between the ages of 60 and 65. And many of us are well capable of working past 65, but we have a very young population, high unemployment rate, and so they're only too happy to see, or what they, those of us they consider aged, over 60, out of the workforce. So it's a big challenge, and and then bringing in new and making occupational health an attractive option for students. There's limited access to training. Currently, there's only 4 universities in South Africa offering a postgraduate diploma in occupational health nursing. And obviously, these programs are offered part-time to try and facilitate easier access for students, because, as I mentioned, 99.9% of the students are working. However, obviously, the students living and working in more rural areas, it's very much more challenging. When I was at Durban University of Technology, we would get students from the Eastern Cape. They would have to travel 600 kilometers to come for 1 day of contact at the university. So they would travel overnight on a bus, attend university all day, and travel back the night after lectures to arrive in their hometowns early in the morning, sort of to go to work at 8 o'clock. So very challenging, and strong commitment to to furthering their qualifications, but it doesn't make it easy for and predominantly women, got families, etc. So before the change in the qualifications and us all getting onto the higher education sub-framework and the national qualification framework, there was more universities offering occupational health, but with the more stringent conditions with respect to the academic staff that are doing the lecturing and the facilities available for clinical practice, etc. Many of the universities have not applied for accreditation for occupational health nursing. And so we have one in the Western Cape at Cape Peninsula University of Technology, one in the Free State at the University of the Free State, Tshwane University of Technology in Pretoria in Gauteng, and then Durban University of Technology in Durban in KwaZulu-Natal. So very limited opportunities. And then the Department of Health limits the number for admissions. So previously we used to take 30 students into a program per year. And now the Department of Health has limited that to 15. So that's halved the number of potential occupational health nurse specialists that we're able to train. And this, I don't know why they've really interfered in the occupational health nursing, because the majority of occupational health nurses are employed in private enterprise. And despite that, the Department of Health hospitals, so all the public hospitals and clinics, which are based either primary healthcare clinic or community health clinics, and the various tiers of hospitals require occupational health nurse practitioners in them. But the same time, the Department of Health has restricted the numbers being admitted. You have to have a letter of permission from the Department of Health giving a number that you're allowed to admit. We've had these changes to the nurse education pathways, which I've spoken about. So bulk of nurses in South Africa have been trained in the diploma program. And as you can see, they have to access a midwifery program prior to accessing a postgraduate diploma. So there's been a hiatus in specialist nurse training for a few years, and that's going to contribute with this aging workforce and many going off on retirement and fewer coming through. There's going to be a real shortage. The other thing is the specialist nurse educators to do the education. So to be a nurse educator in South Africa, you need to have, if you're a specialist nurse educator, you need to have a specialist qualification in the speciality that you're teaching, an occupational health speciality. You need to have a nursing education qualification in order to be a nurse educator. And because it's all in higher education, a minimum of a master's degree. So to find a nurse with that mix is also proving very difficult. And so this is also contributing to reasons why some of these universities have not renewed their accreditation for occupational health nurse specialist training, because to find an occupational health nurse specialist who's got a nursing education qualification and a master's degree is very, they're in very short supply. There's obviously the issues of resource constraints, funding for the universities, funding for students, funding. These students are working, they need to get a permission and time off and be facilitated by their employers to attend school. And it has been helped with the online, you doing some online blended learning. Obviously, it's difficult to do a fully in clinical courses. It's very difficult to do fully online. But I guess with time and AI and the new ways, machine learning and stuff, we'll have more innovative ways of doing that. But at the moment, students still need to attend the university for some lectures, as well as finding time to do their clinical practicals, simulation labs, etc., that are all very expensive. And so in many of our countries, we're very resource constrained. And occupational health is not often seen as a, it's a bit of one of these sort of Cinderella specialities. They're going to pump money much more into ICUs and operating theatres and trauma units, etc. Obviously, there's rapidly evolving workplaces. Emerging risks they challenge the curriculum. The curriculum in higher education is often not very agile. And so, having to try and keep up and keep the changes going, or keeping writing a curriculum that is agile enough to keep addressing these sort of emerging risks and things is a challenge, because also with the accreditation, all the steps that you have to go through, and being a health speciality, you've got a dual accreditation to the Nursing Council, the South African Nursing Council, as well as the Council for Higher Education. And then the interprofessional education challenges, very few programs, if any, in South Africa in occupational health specialities are integrating interprofessional education with other workplace health professionals. So these are some of the challenges that we face in South Africa, and I guess are fairly common across the world. And that's it from me. Thank you very much.
Thank you, Dr. Penny, for sharing that experience that your wide experience in education for occupational health nursing in South Africa. Actually, it's very different here in Peru, and but some of the challenges you just mentioned, I think we are facing very similar issues here. So we would like to invite anyone from the attendees to make questions to Dr. Penny, please. Feel free to make questions. So I would like to start and make a question, Dr. Penny. You just mentioned that most of the occupational health nursing workforce are getting, like there are not so many new generations of occupational health nurses. From your position as educator, which strategy you are working on to get more attention from the new generations of nurses?
Yeah, we don't really, I'm not really aware of any strategies. Again, I think it's very much the same as Dr. Quinton mentioned with medicine, is there's very little exposure during the undergraduate nurse training. In the new programs, I'm not even aware of what is in the new curriculum. In the previous curriculum, for the 4-year diploma and which was a 4-year diploma and a 4-year degree, the diploma, I don't think there was any exposure to occupational health nursing. And in the degree, they had one lecture, and I think they had, if they were lucky, they got to visit a factory. And because the person who was the nurse educator who was facilitating that, it fell under the community health module. That in South Africa, community health obviously is a strong subject, and it's a module that goes across 3 years of nurse training. But they would spend one morning or one day on, being introduced to occupational health, and the educator probably had no experience of occupational health anyway. And then if they were very lucky, they might have organized a trip to a factory, but there was no sort of occupational health focus in that visit to a factory. It was more about walking around the factory and seeing how, for example, chocolates are made, and then we can eat as many chocolates as we like. So we loved going to the factory, but there's no promotion of occupational health within the nursing undergraduate programs. It's an area that we need to think about. What are we going to do? Because you have to have the speciality to work in the field. One of the attractions to it is that there's many private nurse practitioners working in occupational health. So they have their own practice in occupational health, and they go into companies. And so people, some nurses who want to have their own business, see occupational health as a way of being able to do that. So that's the only sort of cherry to attract. But when they haven't had exposure to it, they don't understand what it's about. And they sort of come to it by chance. Very often they come to it because they're looking for a sort of side hustle and wanting to earn a little bit of extra money out of their normal work hours. And so they will do a short course in audiometry and spirometry, and work after hours or, on leave days and weekends as technicians just conducting audiometry and spirometry for an occupational health nurse practitioner in an occupational health setting. And then they find out more about occupational health and then are more attracted to it. Yeah, but it's something that we should work on. But I think there's a challenge just getting young people to want to come into nursing itself. Thank you, Norval, for the question.
Okay, thank you, Penny.
Dr. Penny, I have a question for you. While appreciating the challenges that South African nurses face in specializing and practicing in occupational and environmental and safety nursing, the practical aspect is the evolution of the society and the need of the organization to employ the nurses and maybe in-house training of the traditional nurses into occupational health nurses, because that is the entry point where competency improves substantially and in a fast pace. How is the situation in uptaking by the organization and then training in-house so that the competency they acquire is relevant to the organization they work in? Gradually, this volume, if increases, will that be a practical way of evolving occupational nursing profession in South Africa?
Yes, thanks, Dr. Rajiv. Yes, and many organizations used to do that. That's for me, for example, that when I started in occupational health, I didn't have the specialist qualification. I started working in a company in Nampak, one of the Nampak companies, and they afforded me the opportunity to go and do my specialist qualification. However, now, I think with cost constraints and the legislation being very much more stringent about certain activities that need to be done with regard to occupational health has to be done by a qualified specialist person, restricts those opportunities for in-house kind of, employing someone. Because more often than not, there's only one occupational health nurse practitioner in an organization. And so she has to come in, or he has to come in already qualified. Some of the bigger organizations, they do that. They will employ a general nurse or a professional nurse and then afford them the opportunity to train as, into the speciality. But majority of enterprises, it's the nurse is working on her own. Some of the mines, some of the bigger organizations, yeah, that is an entry point. Thank you.
Thank you. Thank you so much.
Thank you. Due to the time limited we have, we thank you, Dr. Penny, for your presentation and for sharing with us even of the time difference.
My pleasure.
We hope you can now you can take a break and well, we would like to invite to our next speaker, who is also I'm going to be the host again, and I would like to introduce you to our third speaker. Check. Okay, I'm admitting new participants. So we introduce you to Dr. Ivan Nilanjan. Dr. Ivan Nilanjan is a senior lecturer at the Durban University of Technology, Department of Community Health Studies, Program Environmental Health, Chair of Professional Certification Committee, South African Institute of Occupational Hygienists, previously worked for the government regulator in administering occupational health and safety legislation. He lectures in occupational health and safety and environmental law. So welcome, Dr. Ivan. It's a pleasure for us to have you here. Now we'll make you host so you can share your presentation.
Good evening, Dr. Novell, and good evening, everyone present. Thank you for this opportunity. I'm going to share my screen. Dr. Novell, are you able to?
Yes, I have made you host so you can.
Are you able to see my screen?
Yes, it's loading. It's still loading.
Okay.
I have made you host, so maybe you can try to share again.
Okay.
And so people who would like to make questions to Dr. Ivan, he will make a presentation about industrial hygiene. So if you have some questions, you can be typing in the chat. Now it is loading. Now it works. We can see your presentation, Dr. Ivan.
Okay, I'm just going to put it onto. Okay, good evening, and thank you very much, Dr. Novell, for this opportunity. I really appreciate it and grateful for it. This afternoon, I'm going to be talking to you about education and training in occupational hygiene, basically the barriers and innovations that we have basically done in South Africa. So just following on from Dr. Penny Orton, we are colleagues at the same university, Durban University of Technology, and we work closely together with occupational health nursing and occupational hygiene as such. So it's a good to follow on from her. So in terms of education and training in occupational hygiene, we basically have a system in South Africa that's basically close to about 35 to 40 years as a profession. And essentially, what has happened over this period of time, we have a very structured process in terms of equipping professionals in occupational hygiene. And basically, we will train them in the various principles of anticipation and control and evaluation of occupational hygiene protocols, frameworks, as well as the legal framework for these requirements, because legislation is a big driver in terms of the occupational hygiene framework. And in the South African context, we have the Occupational Health and Safety Act. And in the act itself, it basically makes it mandatory for employers and industry to basically employ the services of occupational hygienists in the country as such. So basically, that's one of the major drivers that we have in terms of occupational hygiene. So the training is generally a 4-year professional degree, and over and above the 4-year professional degree, um, basically graduates from the area of Bachelor of Science in Environmental Health, for example, do short courses through the Occupational Health Hygiene Training Association, as well as peer-to-peer learning and so forth in the area of occupational hygiene. So essentially what we are looking at in terms of promoting occupational hygiene, we are looking at engaging with our students and also looking at providing them with practical experience. And as a professional body, the Southern African Institute of Occupational Hygiene also forms part of the stakeholders in the legal framework in terms of Occupational Health and Safety Act, They have a seat of their in what we call the Advisory Council on Occupational Health and Safety. So basically, the Ministry of Labor uh, engages with a specialist on the committee as such. So essentially, when we talk about a tripartite, this is an important area where we're looking at trade unions, employers, and government forming part of it. And in addition to those three parties,
Excuse me,
they
Dr.
also
Ivan.
engage the specialists.
Excuse me, Dr. Ivan. I think some of the participants cannot see the slides transition. Which
Okay.
slide you are, please? Sorry for interrupting you.
Okay. Are you able to see it now?
It's now in the first slide. Only the first slide we can see it.
Should I? Is it still on the first slide?
Yes, it's still in the first slide. Maybe you can click on in the left side in the number 3 or 4 on the left side.
Okay, then we
Ivan, I think
Yep.
it needs to go on to slideshow. So if you click on slideshow first in the top,
Yep.
and then
Okay, then we
from,
stop sharing and reshare.
okay.
No, now we cannot see. It's loading. It's loading. Yes, now we can see the education and training programs on occupational hygiene.
Okay. So is it moving?
No, it's only in the education and training programs slide. I think it was the second slide.
Try just click on the slide and it should move to the next one.
Okay, is it moving now?
Yeah.
Yes. Thank
Okay.
you.
Okay, apologies for that.
Never mind. Thank you.
Yeah. Okay. So essentially, well, we're going to be looking at training in terms of our programs, we basically incorporate occupational hygiene in our curriculum. And in terms of our curriculum, what we basically look at, there's a 4-year degree that we basically forms part of occupational hygiene. So in the in the South African setup, what we have is basically a 4-year degree called the Bachelor of Science in Environmental Health. And in this qualification, the second, third, and fourth year, we basically specialize in occupational hygiene. So we basically, in our curriculum, we basically incorporate all the principles of occupational hygiene over these 3-year period, and essentially incorporating this and aligning it to the sustainable development goals that are basically in place in South Africa and in the world in terms of decent work and innovation. So in terms of the Southern African Institute of Occupational Hygiene, the legislation has basically given this organization the ability to basically accredit professionals in terms of occupational hygiene. And essentially, in terms of this professionals, there are 3 categories: the occupational hygiene assistant level, the occupational hygiene technologist level, and the occupational hygienist. So essentially, it's a progressive area. And in order to start the profession at the entry level, in terms of occupational hygiene assistants, generally a person coming straight out of school, grade 12, can enter the profession basically by completing a short course in the basic fundamentals of occupational hygiene, and then basically getting access into the profession. And this particular organization, the Southern African Institute of Occupational Hygiene, has got approximately about 1,000 members in South Africa and internationally as well. And more than 50% of that membership basically falls in the category of occupational hygiene assistant entry level. In the second level, in the technologist level, this is basically a person with at least a 3-year formal qualification, and basically has acquired at least about 2 years of experience in occupational hygiene. And essentially up there, we have about 25% of the membership, around 250 or so occupational hygiene technologists. And then at the top level, the registered occupational hygienist level, we basically have a person with a 4-year professional degree, and basically with at least about 5 years of experience practicing as a registered occupational hygienist. And in this particular category, we have about 250 basically specialists. And when we get to the barriers up here, I will talk to you about the occupational hygienist. So essentially what we have is basically a setup from occupational hygiene assistant, progressing to the occupational hygiene technologist, and then progressing finally to an occupational hygienist as such. But the bulk of the entry level is at the bottom of the level of in terms of occupational hygiene and assistants entering into the profession. So essentially, what we look at in terms of here, we look at the 17 skill sets that an occupational hygienist has to basically cover. And in terms of the 17 skill sets, what we're looking at basically health risk assessments, generally chemical stresses in terms of asbestos, lead, and so forth. We'll be looking at toxic metals, physical agents, training on noise, heat, lighting, and then other stresses, for example, ergonomics, indoor air quality, and psychosocial stresses. So these 17 skill sets basically are incorporated in the curriculum as well as in the professional board as such. And just to basically, just to look at the skills matrix, I mentioned there are 17 skill sets up here. At an occupational hygiene assistant level, generally, what happens here, when the candidates have completed their degrees and have the necessary experience, they then apply to the Southern African Institute of Occupational Hygiene, depending on which level. So as an assistant level, generally, this is a 1 hour examination, a multiple choice type of examination, and the candidates generally have to score at least 60% in order to become an occupational hygiene assistant. From there, if they want to progress to a technologist, then the pass mark goes up to about 65%. So they do a written examination up here and an oral examination in this particular category. And after 2 years as a technologist, they can then apply to become a registered occupational hygienist. Again, writing a formal examination, a 3-hour written examination, and then also undergoing a oral assessment, basically conducted by senior occupational hygienists in the profession with at least about 5 years of experience. And up here, basically, the candidates have to obtain at least 70% pass rate. So in terms of your qualifications, basically to become a registered occupational hygienist, you require at least a 4-year professional degree, and the professional degree can be in fields of biology, chemistry, chemical engineering, mechanical engineering, or environmental engineering. And also, in addition to that, basically candidates should also look at doing the ICET, International Certificate Courses on Occupational Hygiene Training Association, so that also gives them a sound grounding in occupational hygiene. So in terms of the NQF 8 level, this is a 4-year professional degree, or candidates can have a higher qualification than that, a master's or a PhD in these areas, and basically look at specializing in occupational hygiene. So currently, there are 7 universities that are offering the BSc Environmental Health, the 4-year professional degree. And essentially, again, in terms of these candidates, they have a choice to decide whether to basically join, to form part of occupational hygiene, or to basically practice in other areas of environmental health. So essentially, it's a requirement for us to also market the profession, and to also attract these the new graduates into occupational hygiene as such. So it does require us to market it and to make it attractive to basically get candidates. But slowly and steadily, we are basically increasing our numbers. And when we're looking at these particular candidates up here in terms of their experience, we're basically looking at these particular candidates, their skill sets that we are also looking at is basically to be the communication skills, the ability to do report writing and so forth, specific skills that we are looking at in terms of occupational hygienists. So that's another area that we need to look at, is to attract the right candidates into the profession that is basically required. So in terms of the Southern African Institute of Occupational Hygiene, they are basically recognized by the International Occupational Hygiene Association, and basically they form part of the National Accreditation Recognition Agreement. So essentially what this means is that once person is registered as an occupational hygienist and meets the requirements of here, he or she is able to practice internationally, globally, and for that matter, they can basically be employed globally, and many of them is basically recruited as soon as they are graduated. They basically get employed overseas, particularly in countries Australia, New Zealand, the Middle East, and UK, Europe, and so forth. So basically, they become very they become in great demand as such as soon as they qualify. Once they complete and get to the stage of a registered occupational hygienist. And currently, we as an organization, the Southern African Institute of Occupational Hygiene has got accreditation from the international body up until October 2029. So basically, what actually happens up there is that they come and do an audit and check the systems, the quality management systems, the assessment processes that we are basically implementing, and also to look at the rigor and the level of the examinations that we basically conduct, and if it is aligned to the international occupational hygiene requirements as such. So essentially, we have basically got that accreditation, so that makes it also more attractive for our basically our members to basically complete the examination and become basically marketable internationally as such. Over and above that, we have the ICET qualification, the International Certificate in Occupational Hygiene. So the four-year degree gives them a grounding, a foundation, but basically, over and above that, they also are basically encouraged to do the Occupational Hygiene Training Association courses. And they have basically courses, core modules of there that are available, basically in terms of thermal environment, noise, asbestos, and so forth. And very recently now, they have basically provided the mining and mineral processes as such. And that will be specifically for the mining sector that's basically done. So in these courses up here, that's available by the Occupational Hygiene Training Association. Well, what is actually happens is that has an organization, Southern African Institute of Occupational Hygiene, we basically have at least about 10 service providers that we have approved that provides these short courses within South Africa and internationally as such. But it's done, we are basically more the facilitator, and it's overseen by the International Occupational Hygiene Association. But it's basically very comprehensive courses in this discipline, and basically specializing in occupational hygiene. So generally, these courses are about a week, and in most cases they are online. That you can basically do these courses, and it basically supplements your knowledge in occupational hygiene and enables you to pass your various examinations that follow on from here. So in terms of new developments that's happening now in occupational hygiene, what we also find happening now is the real-time monitoring. And up here, generally, when you look at traditional occupational hygiene, where we will look at active sampling using a sampling pump and sampling media, now we have with technology and real-time monitoring using direct reading instruments, basically to give you readings immediately and and continuously reading systems. So basically introducing IT hardware and software into the profession of occupational hygiene. So that's basically one of the new developments that we have, and essentially what you can see up here using these networks. So that this is a new development that traditionally we haven't looked at in terms of occupational hygiene as such, but because of advancements that have happened, particularly these technologies are used in larger organizations such as your mining industries, organizations that generally have a larger budget and so forth, because this particular the type of technology in terms of costing is very expensive to basically look at. So this is in the future what we're looking at. And also now we're looking at portable devices for monitoring, and unlike in the past where we will look at just area monitoring, we can now, there are basically equipment devices that can basically measure stresses directly onto the workers themselves, in terms of basically heart monitors, fitness monitors, and so forth. So essentially, this is the new development that is happening and basically unfolding in this sector. Some of the challenges that we have in occupational hygiene in South Africa is basically access to these courses, and also exposure in terms of the profession. And in terms of representation, particularly in terms of management and leadership roles, there is basically an underrepresentation. But as I mentioned earlier, in terms of members of the Southern African Occupational Hygiene Association, the membership has for females has gradually increased. And if we had to look at over the last 10 years, in terms of membership, of female membership, basically we have moved from 27% in 2015, and now in 2025, it's over 54% are females. So in terms of membership, the numbers have increased, but in terms of leadership roles, that still has to increase, particularly in the industrial sector. But has an organization and has basically has the Southern Institute of Occupational Hygiene. The past president was a female, Ms. Nadia Mandi, and our current president is a female, Ms. Karen Dupree. So in terms of the organization itself, there is many females in leadership position, but in terms of the industry, that still has to come up with there. The other challenges that we also have in the Southern African setup is the fragmentation of legislation, meaning that when we have the legislation in South Africa, we have the Occupational Health and Safety Act, specifically for factories at ground level. As soon as you go to the mines and go below ground level, then you have the Mine Health and Safety Act. As soon as you go into the air, then it's the Aviation Safety Act. And at sea, it's the Shipping and Merchant Shipping Act. So essentially, what happens to the legislation is fragmented, and it's also fragmented in the sense that it goes to different government departments. So the Occupational Health and Safety Act falls under the Department of Employment and Labor, but as soon as you go underground to the Mine Health and Safety, it falls under the another Ministry of Mineral Resources. And as soon as you go into the sea or into the air, then it falls under the Department of Transport. And unfortunately, these three government departments and legislation, they function separately and independently, and they don't interact and basically work together in this field. So that creates a challenge as such in the country as such. And I'm not sure when it's actually going to be actually merged and to have like one government department looking specifically on occupational hygiene or occupational health and safety as such. The other challenge that we have is has mentioned by Penny as well earlier on, is the aging workforce, occupational hygienists. So if you could recall, I spoke about an occupational hygiene assistant, occupational hygiene technologist, and then at the occupational hygienist. So essentially, in order to get to this stage from school to provided you pass each year, you're looking at least between 10 to 15 years uh, before you can actually become an occupational hygienist. So in the current setup, we're probably about the hygienists in the country, probably about 50, probably about 60 to 70% are over the age of 55, and basically between 55 and 75 as such. So it's a big challenge that we have, the aging workforce, and particularly at the higher level of occupational hygiene. And coupled to that is the basically globalization, in the sense that for young people graduating and qualifying as occupational hygienists, the international market is very attractive. Basically, they qualify, they get taken up by international mining companies, the oil and gas companies throughout the world, and particularly with our currency as well. If you look at our South African currency, it's a rand, and if you look at the US dollar, $1 is 18 rands, and if you look at the UK or Europe and so forth, one pound is about 24 rands. So for a young up and coming professional, it's very attractive to basically go overseas. So that's a challenge, and I don't think it's only in South Africa, but I think worldwide, it's basically a challenge that we're looking at. So in conclusion, what we have here is basically occupational hygiene, and the Southern African Institute of Occupational Hygiene basically partners with ICOH, the International Occupational Hygiene Association, with OTA, Occupational Hygiene Training Association, BOHS, British Occupational Hygiene Association, uh, also with the Workplace Health Without Borders, and ICOH as well. We basically form part of it as well, promoting occupational hygiene and health and safety. So in terms of challenges, as we mentioned, the fragmentation of legislation, and in terms of innovation, we have the new digital setup that is coming on, where we have real-time monitoring that's in place now. And we are looking at, particularly in leadership positions, basically to have parity across the genders as such, and basically to basically continue collaborating in the occupational hygiene professions. So that is one of the things that we want to do, is to continue in this area. Thank you.
Thank you, Dr. Ivan. It was great to know about all the advances and innovations in South Africa, especially for for occupational hygiene, that in countries such as Peru, we are still trying to improve the education programs for engineers and physicians who are involved in industrial hygiene. So we would like to invite attendees to make questions to Dr. Ivan, please.
Yeah, Dr. Ivan, it was very insightful to get a glimpse of how occupational hygiene profession is evolving as a specialized profession and becomes attractive in South Africa. I believe it will have more impact if it is diffused across the African continent. There's no doubt about it. It's a great advance that South Africa has made. My question relates to the occupational hygienist professionals. What is the general background that they come from? Like, are they having some specialized education prior to becoming occupational hygienist? Or which stream of school or college education they are drawn from? Thank you.
Okay. Thank you, Dr. Jain. Yes. So basically, in terms of maybe just to answer your first question with regard to Africa, maybe I didn't mention in the presentation, but in Africa we have two new organizations, two countries, Tanzania and Nigeria, that are also now becoming an organization on their own. And as a country, South Africa, in order to promote occupational hygiene. The organization is Southern African Institute of Occupational Hygiene. So one of the initiatives that we have done together with the African Union is basically capacitating inspectors in the SADC region, Southern African Democratic. So what we have done, we have basically over the last 2 years, we have trained. You remember I showed you the Occupational Hygiene Training Association modules. So we have trained about 20 inspectors from Zambia, Malawi, Lesotho, Mozambique, South Africa as well, in occupational hygiene. So in that regard, we have basically also promoted occupational hygiene. And last year, what we also did as an organization, we had our first conference in Botswana, in Gaborone, Botswana. So we basically also looked at basically developing occupational hygiene across South Africa, across Africa as such. With regard to to entering into occupational hygiene, the Bachelor of Science degree in environmental health is one way of getting into the profession. So generally, there has to be a 4-year professional qualification. There are other disciplines, for example, chemistry, chemical engineering, physics, that professionals can also enter into the profession. And more recently now, one of the universities in South Africa has basically developed a Bachelor of Science degree in occupational hygiene, and that is at the Northwest University. But generally, the vast majority of candidates and so forth come from the professions of environmental health throughout in the country as such. Okay, I hope I've answered.
Thank you so much. Thank you.
Thank you, Dr. Ivan. So we're going to present our next speaker. Thank you for sharing with us, Dr. Ivan. There's still some attendees connected, so I'm going to admit them. And now it's my pleasure to introduce you to Dr. Rajiv Kumar Jain, who is the chair of the Scientific Committee on Education and Training in Occupational Health. He's a health and hospital administrator. He has had extensive experience, more than 40 years, in hospital accreditation, quality in healthcare, health administration, including hospital administration, epidemiology, occupational health, child health, hospital and healthcare strategic planning, medical regulation, infectious diseases, health service research, etc. He, besides being the chair of the Scientific Committee of ICOH in Education and Training in Occupational Health, he's the president at the Association of Environmental and Occupational Health in Delhi. So welcome, Dr. Rajiv. It's a pleasure to have you here. I'm going to make you host. I think your microphone it's off.
Thank you, Dr. Novel, for organizing this important webinar where you have been able to join together diverse backgrounds and diverse specialities across the world and across continents. Dr. Quentin, Dr. Penny, Dr. Ivan, and then later Dr. Cameron and Dr. Carmen is a wide spectrum, and I'm really honored and I'm grateful to you for this webinar with an important theme, and the topics that the speakers have chosen covers the entire spectrum of education and training in occupational health across the world. It's really great occasion when you have been able to collect together for the single purpose of promoting education and training in occupational health across the world. Thank you so much. So my area of discussion at this point, after the enlightened speakers have spoken about diverse areas, would be what has been the spectrum of occupational and health and safety education and training in Asia. And this process is an evolving process, as you would agree. We have a diverse economic development and regulatory landscapes across Asia. Education training are offered at the university level through international organizations and by regional and local training providers. At the university level programs, many Asian universities offer bachelor's, master's, and doctoral programs, which are focused on occupational health and safety. Sometimes they're integrated with public health, environmental health, or engineering disciplines, which is understandable as the process is evolving, and it is evolving very fast. Examples include in China, the China University of Mining and Technology, Beijing University, Tsinghua University of Xi'an, Xiaotong University, all offer master's programs in safety science, occupational health, or environmental health. In Malaysia, the University of Nottingham, Malaysia University, Technology Malaysia, and University Putra, Malaysia offer master's programs in occupational health and safety and related fields. In Indonesia, the University of Erlangga offers a master's in occupational health and safety. In Japan, the University of Occupational and Environmental Health Japan provides a master's in occupational health. In Thailand, St. Teresa's International College offers a Bachelor's of Science in Occupational Health and Safety. In Central Asia, in countries like Kazakhstan, Kyrgyzstan, and Uzbekistan, medical and other universities offer undergraduate and postgraduate programs which focus on labor hygiene and occupational health. I shall discuss further the evolution of occupational health and safety education training in India. Initiatives by the international organizations like International Labour Organization and the World Health Organization, they play a key role in advancing occupational health and safety education through regional strategies, partnerships, and educational materials. If we see International Labour Organization in India, they are focused on capacity building, training initiatives, and regional collaboration. In capacity building, the ILO collaborates with the national governments and employers and workers' organizations to strengthen national OHS systems and build capacity through workshops and training. With respect to training initiatives, programs like work improvements in small enterprises, that is WISE, and participatory action training for informal sector, that is PATRIS, are used to train local trainers and improve occupational health and safety in small and medium-sized enterprises and the informal economy, which is a substantial part of the OHS practice in Asia. With respect to regional collaboration, through its decent work team in Bangkok, the ILO has worked with agencies like the Korea Occupational Safety and Health Agency, that is KOSHA, to conduct regional workshops for the Asian countries. WHO activities in Southeast Asia are worthwhile to note here. The World Health Organization has developed regional strategies to address occupational health and safety in Southeast Asian countries, which are largely uncharacterized and impacted by rapid economic development. The organization has held regional workshops to review challenges and identify priorities actions for strengthening occupational health, noting that implementation varies and institutional frameworks are often limited. Beyond formal university degrees, we must understand that the professional and certified training is also an important area. The variety of providers offer vocational diplomas, certifications, and professional developmental training. The common qualifications include NEBOSH, NEBOSH. This globally recognized UK-based awarding body offers qualifications that are available through training providers across Asia. IOSH, the Institution of Occupational Safety and Health, that is ICOH, offers courses like Managing Safely, which is offered in Southeast Asia and is relevant for line managers in any sector. ISO standards, training courses are available for international standards like ISO 45001, 2018 for occupational health and safety management systems. Local providers, organizations like the Asian Safety Council, offer specialized training and certification courses for professionals. At this juncture, we must identify what are the challenges and developments with respect to OHS education. We must recognize that OHS education is expanding in Asia. There are several challenges which persist, like informal economy. A large proportion of the workforce in Asia is in the informal sector, where OHS protection and education are often insufficient. There are implementation gaps. While OHS policies exist in many countries, their implementation is often inconsistent, especially in smaller workplaces. There are new risks like emerging technologies, climate change, and psychosocial stress in the workplace. They are creating new OHS challenges that require updated educational programs. So, after introducing what is happening across the Asian countries and how international organizations are collaborating, I come to India's occupational health training landscape. India, as you know, is a large geography in Asian continent where India is transitioning to a competency-based model to emphasize practical skills and standardized training across various healthcare professions, including occupational therapy and occupational medicine. This approach focuses on a learner's ability to perform tasks in real-world settings, moving beyond the theoretical knowledge to develop essential skills in cognitive, psychomotor, and affective domains. Key aspects include integrating horizontal and vertical learning, providing opportunities for practical application of knowledge, and training in specific competencies like occupational health and safety management systems. The key aspects of the occupational-based curricula are emphasis on practical skills. The core principles is shifting from what a learner knows to what they are able to do in clinical practice. Then standardization is being promoted. New curricula aim to establish consistent educational standards for healthcare professionals nationwide. Third fulcrum is the holistic development. Beyond clinical expertise, these curricula foster crucial skills like communication, ethics, teamwork, and lifelong learning. Last but not the least, the importance of skill-based training. The training focuses on 3 domains of learning, that is cognitive, psychomotor, and affective. In cognitive domain, knowledge of human body systems, occupational diseases, toxicology, and environmental health is emphasized. For psychomotor domain, practical procedures like data collection, record keeping, and the use of computer applications is emphasized. In affective domain, the skills in communication, professionalism, ethical decision-making, and patient education are emphasized. Examples and implementing bodies are Directorate General Factory Advice Service and Labor Institutes, which is abbreviated as DGFASLI, DG Fastly. This body offers a competency-based curriculum in occupational environmental health. Then we have the National Commission for Allied and Healthcare Professionals, NCAHP. In collaboration with the Union Health Ministry, NCAHP has launched competency-based curricula for various allied healthcare professions, including occupational therapy. The National Medical Commission. National Medical Commission has also developed competency-based frameworks for medical diplomas and promotes continuous internal assessment to evaluate competencies. Curriculum content in occupational health has cognitive aspect, practical and clinical skills, legislative knowledge, and mental health. For cognitive aspects, understanding occupational and environmental health disorders, biostatistics, toxicology, and work physiology are included. Practical and clinical skills, data collection and analysis, computer applications, and establishing interventions for safety are included. For legislative knowledge, training on specific Indian acts like the Factories Act, ESI Act, and the Workmen Compensation Act are important areas. For mental health, incorporating mental health, job satisfaction, and work-life balance into the curriculum is an ongoing process. Now, this process is an ever-evolving area where the competency-based curriculum gets incorporated in the existing programs, and more emphasis is based on, when transfer of knowledge and skills is concerned, more emphasis is on where competency in the 3 domains is actually transferred, and they are tested on how much they've been able to get the competency in specific domains. So this is a broad area, but the area is so vast and evolving so fast that it is not possible to dwell into the finer intricacies of this area in this limited time that is available. I would like to again thank Dr. Novel and all the speakers and panelists to be able to have their time for this important area for education and training across the world. We hope that we together in the National Commission on Occupational Health are able to evolve this process further and have similar interactions in future. At this juncture, I also invite you for the next Congress, the Global Congress of International Commission on Occupational Health in February 2027 in Mumbai, India. All of you are invited and collaborate and interact and present your scientific work for the last 3 years. From 2025 to 2027 is a great occasion. So we welcome you to India in Mumbai in February 2027, starting with 14 February 2027. Thank you so much.
Thank you, Dr. Rajiv. It's been a great presentation about all the advances and barriers and challenges for the future in Asia, with a special focus in India and some other countries who has been working a lot in occupational health and safety education. Thank you, and we would like to invite you to stay with us for the roundtable session also, who would be involving early career specialists in different fields of the occupational health and safety. So thank you, Dr. Rajiv. If anyone would like to make a question, please, to Dr. Rajiv. We can also wait for the roundtable session, Dr. Rajiv. So now we would like to introduce our final speaker of this night before we start the roundtable session. So let me share with you for introducing him. So we have our last speaker, who is candidate for PhD, Ali Wing Hakai Chang, who is an industrial engineer with a master's degree in integrated management of safety risk prevention, environment, and quality at the Universitat Politécnica de Catalunya. He also has a master's degree in integrated management of safety risk prevention, environment, and quality at Universidad de León. He's currently working on his PhD research on wellness and health technology at Universitat Politécnica de Valencia. He's ICOH member from Ecuador, and he's also professor at the Universidad Particular de Especialidades Espíritu Santo. So welcome, Dr. Ali Wing. I'm going to make you host so you can share your presentation.
Thank you.
Okay, now you're the host. You can share your presentation, please. Welcome.
Okay, thank you so much. For me, it's a great honor to make this presentation about the education of on ergonomics in Latin America experience and future perspective from Ecuador. I think that today it's this is a very, very important time about some developments about in prevention, in occupational health and safety. So in all over the world, I will be so fast in order to the time, because right now I want to begin about the scope on ergonomics. The scope, it's a very, very important thing especially in Latin America, because normally in Latin America we have some things about the scope of the fields in occupational health and safety, especially in ergonomics, because in Latin America, normal things that ergonomics is only about physical and biomechanical issues. When we talk about ergonomics in Latin America, we only think about some repetitive movements, about postures, about liftings, and it's not only the physical and biomechanical issue in this one. Also, the comfort and well-being, the cognitive ergonomics, and the organizational ergonomics that made the human factors concept that ergonomics is related on with some psychosocial issues, with safety issues, also one. I want to present a perspective about the global education in ergonomics that International Ergonomic Association present all over the world about undergraduate programs that there are in the map. We could see the total of 336 programs all around the world. That is, in Latin America, is only the 9%. If we send the same thing about master degrees, is special ergonomics master degrees programs, there are 273 programs that in Latin America it's only 10%. And even if we present the PhD programs, it's lower than. It's 10 programs in all Latin America, that is less than 5% in all over the world. In some years ago, I made some research for my PhD degree about ergonomics, musculoskeletal disorders, treatment, and return to work. I made a literature review about this one in Manual Jobs that was published in 2 papers and 1 poster in the World Safety and Health and Occupational Health presentation. And in this literature review, I analyzed more than 185 papers all around the world, and this performance that the papers are related in United States, Denmark, Netherlands, Brazil, Spain, Finland, and also one. If we take this, the same outline in the where are the master degrees programs, where are the undergrad programs, where are the PhD programs, are the same that we show here about ergonomic research. So at the end, in this in this study, we could see that education and research development are related, are very, very related, with the same barriers that there are all over the world. Resources from high-income countries, legal security, and defined legal bodies, there are the same barriers for research than education all over the world. Even the International Ergonomic Association, they one other barrier, it's about the purpose of education. The purpose of education is to make competence. Competence, it's about not only education degree, it's about skills, it's about experience. So at the end I think that ergonomics have the same problem maybe in occupational hygiene, that the competence need to be validated, and it's not so easy to perform all the competence that it needs. So the International Ergonomics Association recognized the competence of an ergonomic professional about foundation knowledge, the measurement analysis, the evaluation skills, recommendations, implementations, scientific skills, and professional behavior. So we need to know about the whole scope that and professional need to perform. So at the end, as the professor said about the occupational hygiene, maybe in ergonomics we need to manage some certification bodies. The certification bodies that all over the world are recognized by the International Ergonomics Association. It's in these 8 countries that we could say Australia, Brazil, Canada, Europe, Japan, New Zealand, South Africa, and United States of America. So the facilities that we have is that these certifications are international. We could take the same certification in any place of the world. And maybe this is a really good opportunity. It's a really good opportunity to make this certification of the professionals that we need. At the end, the world is moving in different velocities. In one place, we could saw some special positions to evaluate the risk in ergonomics. Normally, quantitative, qualitative or semi-qualitative methodologies are following all over the world. But in another thing, in another way, we have some develops of cobots, wearbots, the develops about biomechanical specific analysis that we need to research the movement, about the interaction of ergonomics and artificial intelligence. So at the end, we think that all the whole idea of ergonomics, it's evolutioning in another velocity all over the world. Some institutes are helping to Latin America to reach this goal. Like the Instituto of Biomecánica de Valencia, in this, the IBB, it's an institute that they are working with some countries in Latin America in order to perform biomechanical labs, to perform some programs, educational programs, and visits to another companies in order to perform better education. Another institute is the SCENEA. The SCENEA is they are in some Latin America countries and even with some companies that they are performing not only educational programs, even for studies and researchers that are taking on. At the end, the next challenge that we need in the ergonomics is the unified technical and professional criteria worldwide. So if we can't define which is the scope of ergonomics, and if we know about the same scope all over the world, that I think that it's a very good beginning. Standardization of undergraduate and graduate educational programs in the field of ergonomics, because if we compare some programs of ergonomics in Latin America and in Europe or in the United States, all are different. All are different. Yeah, there are some scopes. There are some focus in and maybe when you finish those programs, you could think that you know everything about ergonomics, and ergonomics is very a big scope. Accreditation of new and existing human factors and ergonomic educational programs and professional ergonomists. At the end, I think that the accreditation of the professional ergonomist it's needed that in all over the world will be necessary. Research, development, and practical implementation, and especially go to the next step. No, not to be fear about to make some research, make some opportunities to implement mechanizations, cobots, and even the exoskeleton, the exoskeletons that they are using all around the world. So this is my presentation. Thank you so much.
Thank you, Dr. Ali Wayne, for sharing your experience in ergonomics program there in Ecuador, which is also very common or has many characteristics in common with Peru and other Latin American countries.
Yeah.
Please, I would like to invite attendees to make questions to Dr. Ali Wayne. You can make it in English or Spanish. I was wondering, Dr. Ali Wayne, which is the profile, the most common profile of the professionals that decide to study ergonomics program there in Ecuador? Are there more physicians, engineers, even psychologists maybe that get involved in these programs?
In many years, the ergonomics programs were focused in physicians. Yeah, in many years. Then some engineers, they are very related about movements and some time and movement programs and studies that they are related, very closely related for ergonomics studies. But I think that it's a very good balance between physicians and engineers in the ergonomic world.
Okay. So, thank you, Dr. Ali Wayne. Is there anyone else who would like to make another question, please? We're about to start our roundtable with our three panelists, and maybe we are going to have another questions that can be related to ergonomics also in the roundtable.
Thank you.
Thank you, Dr. Ali Wayne. So for now, we're going to start our roundtable session. Let me check. Yes, we have here. So I'm going to share to present very I'm going to give you a brief presentation of our panelists. We have Dr. Cameron Kiani from US, who is occupational and environmental medicine physician. He completed his education and training program at the Mount Sinai School of Medicine. He holds a membership in professional societies such as American College of Occupational and Environmental Medicine, ICOM, just like Dr. Quentin. Also, he is member of the Alliance of College of Continuing Health Professionals member, and also part of the International Academy of Independent Medical Evaluators. His field of research includes occupational health surveillance in municipal wastewater workers and enhancing transportation safety through sleep apnea management. Our second speaker is Dr. Carmen Chavez, who is from Peru. She is a specialist in occupational and environmental medicine with 5 years of experience in strategic occupational health and safety management, medical auditing, and implementation of integrated systems. She leads the consulting projects that reduce accidents rates and optimize productivity through evidence-based solutions. She has experience in different sectors such as mining, manufacturing, logistics, construction, insurance, health, and others, with a focus on continuous improvement and national and international regulatory compliance. And our third invited panelist comes from Ecuador. She's the engineer Paulette Jimenez. She studied and she graduates as engineer in auditing and Contaduría Pública authorized from the Escuela Superior Politécnica del Litoral. She holds a master's degree in process improvement, and she also finished a master program in safety and health at work at the Universidad de Especialidades Espíritu Santo. So, welcome to the three of you, and we're about to start a roundtable with some questions from us and from the attendees. We will make some questions in Spanish and other in English. So we would like to start making some questions. Maybe we will start, well, I will make the question in English and Spanish for the three of you. ¿Cuáles han sido las oportunidades que han encontrado al egresar como especialistas en sus campos? Which have been the opportunities that you have found immediately as you graduate as a specialist in your respectively field?
Do you want me to take this first, or?
Please go.
Okay. All right. Well, thank you. It's an absolute honor and privilege to be here, and to share the stage with people like Dr. Jane, Dr. Duran Moreau, and really and Dr. Norville Merichu. Thank you for having me. So as I'm thinking about this question, I wanted to comment on kind of what I'm seeing now, now being 2 years out from fellowship, and then also the kind of opportunities that I'm seeing emerging, and sort of am anticipating will grow in the next couple years. Can you hear me okay?
Yes, definitely.
Oh, okay. So I think the first thing is that the greatest opportunity has really been discovering the sheer scale of unmet need in occupational medicine. When I finished my training at Mount Sinai, I expected to be competing for jobs, that there wouldn't be jobs out there, but I have found a market really desperate for physicians who understand disability management, workplace surveillance programs, regulatory compliance, complex causation. There's just not enough OcDocs out there to really meet the demand. And just briefly, I'll say one of the emerging opportunities that I'm seeing is, and that I think will grow, is occupational medicine in telehealth, particularly around the evaluation of these sort of invisible disabilities, things like long COVID, ME/CFS. I think that we really are uniquely qualified and positioned to evaluate these, particularly around causation and accommodations. These are profoundly disabling conditions. And I know Dr. Duran Moreau has been very much at the forefront of this. And I think that that's something that's emerging right now, trying to understand these conditions, and particularly around accommodations and ADA. And so that's something I'm seeing emerging that I'm excited about.
Thank you, Dr. Cameron. Tal vez doctora Carmen o ingeniera Paulette también quieran participar.
Muchísimas gracias, doctor Norville. Muy buenas noches con todos. Al igual que el doctor Cameron, estoy muy feliz de que nos hayan considerado el hecho de recién terminar la especialidad. De todas maneras, es un reto porque pasas de la etapa formativa allá al mercado laboral. Y bueno, tengo que decir que he tenido la oportunidad de emprender a través de mi consultora y esto me ha permitido desarrollarme en distintos sectores. Nosotros en la especialidad hacemos rotación en distintos tipos de rubros de empresas y ahora también con la consultora veo, por ejemplo, el rubro de manufactura, logística, minería, servicios, y esto me permite adaptar los conocimientos que he adquirido en la especialidad a los distintos contextos laborales, porque cada rubro es muy particular y difieren y los requerimientos son distintos. A su vez, esta oportunidad me está permitiendo liderar equipos, que es algo que, por ejemplo, se enseña en la especialidad, porque al ser residente uno, pues estás aprendiendo, pero luego cuando pasas a ser R2, ya tienes que liderar a tus R1. Y cuando eres R3, en mi caso yo fui la jefe de residentes de medicina ocupacional, pues tenía que liderar a todo el equipo y algo bonito que se hizo en la especialidad acá en Perú es que nos integramos con todas las sedes de la especialidad en Perú y formamos un equipo de aprendizaje. Entonces, esto me ha permitido trasladarlo a ahora ya trabajando, liderando distintos equipos, enfermeras, psicólogos, encaminados a cumplir el objetivo que es brindar bienestar, promover la salud y promover la productividad. Creo que finalmente la oportunidad que he encontrado también es la de por fin empezar a hacer investigación. Creo que esta era mi gran deuda y junto con AICO, a través también de su liderazgo, doctor Norville, he empezado a hacer investigación. Eh, Ahora estoy realizando junto con un equipo de residentes también estudios sobre costos de los accidentes de trabajo en el hospital, por ejemplo, y ya nos están mostrando dónde invertir para que esto sea de forma estratégica, lograr disminuirlo, redistribuir el dinero y ya no sea un gasto, sino una inversión.
Muchas gracias, doctora Carmen. Muchas gracias. Ingeniera Paulette, quisiera también.
Hola, muy buenas noches. En primer lugar, gracias por la invitación a este meeting. Y respondiendo la pregunta, bueno, una vez que obtuve el título de masterado en seguridad y salud ocupacional, me he encontrado con la oportunidad de poder integrar todos mis conocimientos, porque no solamente tengo esta maestría, sino que también tengo otra maestría. Especialmente los he podido integrar en los sectores como logística, en industrias productivas, también en empresas que tienen un ambiente hospitalario e inclusive en comunidades, donde cada vez existe mayor la apertura hacia la prevención de riesgos, el cumplimiento normativo y la implementación de sistemas de gestión que aportan tanto a la productividad como al bienestar de los trabajadores. También he tenido la oportunidad de poder estar en una consultora junto con Alwin, que se encuentra también aquí en el meeting. Para mí ha sido algo gratificante porque también he podido participar en auditorías bajo estándares internacionales, lo que me ha permitido ampliar mi campo de acción.
Muchas gracias, ingeniera Paulette. Vamos a poder profundizar un poco más acerca de lo que nos han respondido justo en relación con la siguiente pregunta. We're about to go even deeper in the first question because the second question is related to the first one, Dr. Cameron. So the second question is, which have been the most difficult challenges and barriers that you have been facing as specialist, in your case, as occupational and environmental medicine physician, since you started working as a specialist?
Yeah, thank you. And this is a great question. And I think that for me, the biggest challenge I've encountered is that most other physicians, most stakeholders don't understand occupational medicine's unique value proposition. They don't know all the things that we do. They don't know that we are the only specialty that trains in forensic examination, in workers' compensation from day one. They don't understand that while other physicians occasionally encounter these systems, we navigate this landscape as a core competency. They don't understand that we can evaluate a sick building, we can evaluate cancer clusters, we can assess reproductive hazards, that we understand risk, vaccination protocols. I really think that we are the Swiss Army knife of specialists. And while the general public, maybe other specialties, maybe institute don't fully understand that yet, I think that they will catch up. And so I think that is one of the challenges, but I do think that it's also changing through efforts like this, hopefully.
I remember that in Texas, when we were at the American College Conference, one of the topics that were treated in one of the sessions was about the situation of NIOSH there in USA. So, do you think that if that that context affect to occupational medicine physicians, let's say, opportunities, especially during this last year?
Is that a follow-up for me?
Oh, yes.
Oh, okay. Yeah. That's a really astute question. And yes, I remember this discussion. And since then, I think we have seen more challenges to kind of establish knowledge. And I think in this current landscape, where sort of and I don't know if that where questions are being brought to vaccination protocols, maybe post-exposure prophylaxis. Dr. Manny Barinji and I were talking to this, and she was the one that kind of centered this idea. I'm hoping that government bodies, that institutions that are looking for guidance will come to occupational medicine doctors, because we are the specialty that we are the medical directors. We manage vaccination compliance, we manage post-exposure. And so I think that we are more essential than ever. And I'm hoping that our visibility increases during these unfortunate circumstances. But I think that at this current time, we are really essential, and I'm hoping our visibility increases.
Thank you, Dr. Cameron. Before going with Dr. Carmen and Paulette, there is one question from Dr. Rajiv.
Yeah. So this phrase of Swiss Army knife of all specialities is so wonderful, because why do you need a Swiss Army knife? In life, you need Swiss Army knife when you have nothing else available and it comes to your rescue. So instead of feeling disheartened, I feel this is an encouragement that you do things which nobody can do. When every other specialty is in crisis, they need somebody who knows the subject, and it is the occupational health physician who helps them to solve riddles. And I've seen this so many years across organizations, that the competency is is recognized by organizations, especially large organizations, especially organizations which work in different geographies across the world, and especially organizations which value human productivity and which value the investment they make in employees or the people who work for the organization's growth. So I feel that is a unique proposition that occupational medicine brings to the fore across continents. But thank you for this phrase.
Yeah. Yeah, and
all specialty. Wonderful.
Dr. Jane, thank you for and you know this more than anyone, given all the spaces you have been in and that you have occupied. And I really think that that companies, institutions that partner with occupational medicine are going to be saving themselves money, preventing injuries. They're avoiding mismanaged claims, and because I think we really do. We look for non-zero sum solutions. We don't try to. We don't just see the patient or the employee in just by their symptoms. We're thinking about the entire ecosystem. Would you agree? I don't know. That's been my experience, or at least that's how I think I was trained.
Yeah, thank you. Thank you, Dr. Cameron. I don't know, tal vez doctora Carmen, ingeniera Paulet, quisieran también comentarnos acerca de las principales dificultades y barreras en relación a lo que ya ha comentado también el doctor Cameron.
Y doctor Norville, justo lo que comentaba el doctor Cameron me hacía recuerdo a cuando estaba en primer año de la especialidad y mis compañeros de otras especialidades me preguntaban, ¿qué es eso? ¿Qué es medicina ocupacional? ¿Qué se hace allí? Y entonces yo entendía que hay tanto, tanto por hacer, por difundir en nuestra especialidad, porque yo misma recién la conocí en el 2020 con pandemia y me enamoré de la especialidad. Y esa barrera de la que habló el doctor Cameron, donde nuestros pares, los demás médicos no conocen la especialidad y no la entienden, también se traslada a las empresas, porque una de las principales barreras es esta falta de sensibilización de los empleadores respecto al verdadero valor y estrategia que es un servicio de seguridad y salud en el trabajo. Y así como que hay que convencerlos a ellos, hay que tener habilidades de negociación. Lo mismo sucede también con los trabajadores, por ejemplo, los que participan del Comité de Seguridad y Salud en el Trabajo, que probablemente no se encuentran lo suficientemente empoderados para levantar la voz. Entonces, como bien decía el doctor Cameron y lo estamos viendo, es necesario seguir hablando de estos temas. Es necesario mostrar todo lo que significa la medicina ocupacional. Y otro punto importante que considero también que es una barrera es la fragmentación de datos, los datos aislados, y esto dificulta la toma de decisiones basadas en evidencia. Lo he visto mucho. Y es importante que el médico ocupacional tenga la estrategia de analizar toda la información que se tiene para así tomar decisiones basadas en evidencia.
Gracias, doctora Carmen. Mi ingeniera Paulet.
Sí, buenas noches. Como dificultades y barreras, lo que yo he podido observar ha sido el nivel de conciencia y cultura preventiva, que en ocasiones es bajo, a veces es nulo, en ciertos sectores, donde se sigue también viendo que la seguridad lo consideran como un gasto y no como una inversión, como un área que viene a ser una aliada, una estratégica. A esto también se le suma en ocasiones la limitada disponibilidad de recursos en pequeñas y medianas empresas para poder implementar medidas de acciones correctivas. Adicional a eso, también tenemos, bueno, lo que he podido observar también ha sido la resistencia al cambio por parte de algunos trabajadores y de hecho de mandos medios.
Bien, pues muchas gracias. Vamos a pasar con la siguiente pregunta, que en realidad va a ser como la pregunta 3 y 4 juntas, porque están muy relacionadas. Ah, ¿Cuál consideran que ha sido su componente o la competencia de formación la que más han empleado una vez que han empezado a trabajar? Y cómo, si ustedes tuvieran la oportunidad de complementar la educación que ya recibieron, ¿cómo lo harían? So, if you, based on your experience, which have been the most important competencies that you got when you were under training in your education program that you feel you have used most when you started working? And if you had the opportunity to improve the education program that you were studying, in which manner you would improve that program?
I really, Dr. Norville, I think I really like this question, and I'm glad that you positioned it. And so I think for me, the most impactful part of my training was learning to see the workplace through the worker's eyes, not just as a medical professional, not just their symptoms, but really like their lived experience. So like when I evaluate like a warehouse worker, I don't just ask, what do you do? I don't just ask, how are you feeling? I do ask those questions. I ask those questions, and then I also learn what their experience, what they are doing day to day, in a way that I don't think other specialties. I think it's not that they couldn't, or it's just that they don't have the time for it. So I learned that they reach overhead 400 times a shift, that they scan items every 11 seconds, that they can't take bathroom breaks without it affecting their metrics or some sort of alarm going off. And I think that for me, that has just been so impactful, really understanding the granular details of how work is actually performed, the lived experience. That component of my training has really transformed not just how I practice, but how I see the world and the way I hope to shape it, and really who I am as a person. And it's, I think, and I'm sure others here will agree with that. It's really a privilege to be with patients in that space, hearing these things and understanding their life experience in ways that no one else in their life really has or does. I don't know if that makes sense.
Definitely. Definitely. And I really agree with you too. Thank you, Dr. Cameron. I don't know if Dr. Carmen or Ingeniera Paulette would like to make any question or would like to give us your comments, your thoughts about these questions.
Sí, doctor Norville. Creo que como alguna vez conversábamos, la especialidad de medicina ocupacional y del medio ambiente es una muy buena especialidad en Perú. Eh, yo hice la especialidad en el hospital más grande de mi país, con más o menos 7.500 trabajadores en planilla y otros tantos más con otro tipo de modalidad. Entonces, la gestión de tal magnitud de trabajadores creo que te brinda habilidades que te permiten enfrentar escenarios con mucha mayor facilidad. Pero además, algo muy bello de la especialidad en Perú, y no solamente de medicina ocupacional, sino de todas las especialidades en Perú, es que te permite hacer pasantías internacionales. Entonces, eso te permite entender distintos contextos. En mi caso, yo fui a Italia y recuerdo mucho a un doctor, en realidad fue un ingeniero que me marcó mucho su clase, pero dijo algo que me hizo recordar a mi maestro, a mi tutor. Decía, él, es importante no solo ver el árbol, necesitas ver el bosque. Y yo creo que eso es lo que me ha brindado la especialidad, eh, poder pararme y decir cuál es el bosque aquí. No solo debo de enfocarme en el árbol y tratar de ampliar mi visión lo más que se pueda. Y en cuanto a tal vez qué mejoraría, porque definitivamente hay muchas cosas por mejorar. Yo amo la especialidad, amo mi formación, pero definitivamente hay muchos aspectos por mejorar. Y creo que algo que ayudaría mucho es mayor formación en la gestión de datos y herramientas digitales. La tecnología avanza a pasos agigantados y el médico ocupacional no puede quedarse tras de esto, sino tiene que aprovechar toda esta tecnología. Y además creo que es importante fomentar las competencias en cuanto a liderazgo, comunicación y negociación sobre todo, porque gran parte de nuestro trabajo es influir directamente en la cultura de una organización y para eso tenemos que vender la idea. Yo creo que mayor entrenamiento en ello sería genial.
Gracias, doctora Carmen. Ingeniera Paulette.
Bueno, el componente más relevante que yo he podido identificar ha sido la gestión integral de riesgos. ¿Por qué? Porque me ha permitido integrar conocimientos técnicos como mediciones ambientales, mediciones ergonómicas, normativa legal, controles operativos. Lo he podido combinar con habilidades de liderazgo, capacitación y comunicación. Y esta combinación ha sido clave para diseñar estrategias realistas y efectivas. Yo complementaría mi entrenamiento con habilidades blandas como liderazgo, negociación, comunicación afectiva, también inteligencia emocional para saber manejar la resistencia al cambio que anteriormente había mencionado y promover la cultura de seguridad en todos los niveles. Adicional a eso, estaría también resaltando las herramientas digitales, análisis de datos y también implementaría la parte de automatización de procesos en el área de seguridad y salud ocupacional.
Muchas gracias, ingeniera Paulette. Am, Vamos a hacer antes de hacer la última pregunta, como están presentes todavía parte de los speakers, quisiera invitarlos también de lo que han comentado ya los panelistas, que quisieran ellos también aportar desde su experiencia ya en la formación, los programas de formación. So, based on your experience in education and training programs for the speakers, Dr. Aliwin, Dr. Rajiv, Dr. Quentin, Dr. Penny, Dr. Ivan, if you are still connected, based on your experience and what you just heard from the early career specialist, which would you think it would be a good opportunity to improve the education programs that you are leading on your countries?
Well, if I could speak, I think that all the educational programs, they are related about offer and demand in all the companies. As Cameron said, if the companies don't know, and even there are some times that even between us, we don't know what another professional do in their job. So I think that first we need to visualize to make some important that what is the scope that we need to follow in all our specializations first. Then we to make some more offer, we need some policies, we need some necessities in the market for the professionals. So thank you.
Thank you, Dr. Aliwin. Maybe any other from the speakers that would like to add something about this question?
This is about what we would add to training.
Yes.
Just a small and very well said just now. It's I think some of the panelists here who speak English better than me, even though it's my native language. But I think two small things. I think one is I think we're already the leading specialty as it relates to sort of like forensic evaluation, and I think we can hopefully expand that excellence to some of the emerging disabilities I discussed earlier, long COVID, so chronic fatigue, these sorts of things. And we already have the expertise. I think we just need to apply it to these emerging conditions that don't have established protocols. And I think the other one that comes to mind is I think we already integrate sort of understanding of business and risk into our training. I think the next step is kind of understanding it at a more formal level, formal business strategy training, kind of teaching residents how to communicate, return on investment for prevention and safety as a competitive advantage rather than just a cost center. It is maybe the next step.
Okay. Thank you. And our last but not least question, but not least important question, is in just one sentence for the three panelists, how do you see the future of your field, of your specialty in your home country and with an international approach? ¿Cómo ven ustedes el futuro para su respectiva especialidad, ya sea en su país de origen y a nivel internacional?
I can answer this quick.
Quentin tiene la mano levantada, perdón.
Oh, perdón.
Oh, go ahead.
Sorry. Who wanted to participate? Who had the hands up?
Yeah, it was me.
Oh,
yeah,
please,
if
Dr.
it may, but
Quentin.
I'm happy to wait if it's not
No.
my turn to talk.
No. Please go ahead.
Yeah, no, thank you. I was, I believe it was Dr. Leon who was mentioning this about, all of the fact that the system, you posted in the chat, the fragmented system that we have, and we've been discussing about making sure that employers know that we exist and trying to convince them through studies on ROI and stuff like this. The thing is that it feels like Groundhog's Day for me, because it's been years that we are, hearing about this, and the medico-economic studies exist for decades. Like, it's probably we can find things as old as 50 years trying to prove that if you invest so many dollars in prevention, you're gonna get an output of $2 or something like this. There are papers on this. So I'm not sure that it's, we can still continue, but I'm not sure that the employers do not ask the support of OCMED docs just because they don't know about it. It's because it doesn't create immediate value added to the business. It is a cost, they have to pay for it, and the money they're gonna get out of it is for later. And it's kind of difficult to appraise, like how you can quantify the money you're gonna get if you're avoiding accidents, if you're avoiding diseases and fatalities at your workplace. And notwithstanding the fact that companies can negotiate with workers' comp, they can ask for discounts, there is a real operating leeway for businesses to try to reduce their costs, even though they are having some risks. So really the path that I'm seeing as a way for us to make significant progress is to remember that occupational health should be governed with the tripartite field. So tripartite is the way ILO is organized. It means that it associates representatives of employers, representatives of workers, and governments. And we tend to forget that governments have to step in. They have to provide the laws. They have to provide the mandates. They have to provide the legislation. And if you look at the recent conventions, the ILO conventions, the later was one, the 190 on harassment and violence at the workplace, and the one that has just been adopted on biological hazards. Those really push for better occupational health and safety in the field of psychosocial risks and in the field of biological hazards. And ILO has been very reactive in creating this normative framework, responding to the pandemic, basically, and looking at other biological hazards. Then those conventions should be ratified by member states, and it should cascade through the different levels of legislations. And I've been discussing about this with an ILO expert, saying, yeah, if you remember, like years ago, working for kids, children work. Now it's prohibited under the fundamental rights of workers. We need to eradicate the worst forms of child labor. It was not a dominant thinking worldwide 50-something years ago. We've made progress with legislation, with the influence of international associations. I really think that our advocacy work should be towards governments, because a business alone in a competitive world is not going to cut their own margin, their own value added in the short term to do occupational health. Even though it brings money later for the business, it's not helpful immediately to them. So we really need to count on government support. And I think our efforts need to go there. So this is why I really believe we need to work with the ILO. We need to lobby our elected officials and to promote our activities, but at a political level. I'm not sure that businesses alone, and especially if there's just one that does this, in the field of concurrence, it may be difficult to translate it to practice. So that's my view on this. This is how I don't get depressed.
Can I respond to that briefly?
Please.
Dr. Durán-Moreau very eloquently said, and I just a brief follow-up or response is, and I agree, I feel like I've heard the rhetoric frequently, and it was saying it myself. Do you feel the same, even in, I feel like in Canada, where it seems like maybe there would be more of a longer term horizon looking at the return, that even in that sort of environment, that appealing to the potential cost savings, because in the US, everyone's just focused on the next quarter, that those arguments still don't really connect, and that the legislative path is really the way to go.
Yeah, thank you, Cameron. I really think that the horizon for business owners is exactly the same, whether you're in the US or in Canada, especially that we have businesses that are across our two countries. So really, I don't think that there is much difference. A lot of businesses are very short-term oriented. There's an awful lot of turnover. And if you work with businesses, and you partner with a specific director whose portfolio is with occupational health, you'll see that like within the next 2 years, they've moved to another position. Like there's so much volatility in organizations. So everything is quick. The timelines are very much short term in my experience with businesses. I'm not sure there is much international differences, and I would expect that all of our colleagues in the call would experience something somewhat similar.
Another area I feel, Dr. Quentin, you would agree, there is definitely a need for better coordination and synergy between International Labour Organization and World Health Organization. Because unless they do that, the implementation across countries across the world will not happen, will not keep pace with the evolution that is happening. Major challenges, especially in Asian countries, is the coordination between the two sectors, that is labor welfare and health. Unless they collaborate and effectively collaborate on the ground, not even at the top level, sometimes it does not percolate down. So the crunch happens, or the real cutting edge, is coordination at the ground level between health and labor.
Thank you, Dr. Rajiv, Dr. Quentin, Dr. Cameron, for this very interesting participation on this question. And well, we thank all of you for being until this time, even up to this time now. And for our panelists, and of course our speakers, our invited speakers, I would like to make the last but not least important question, which is how do you see the future of your respectively specialty, occupational medicine, hygiene, occupational health nursing, or ergonomics in the future in your home country and with an international approach? So, tal vez alguno de los... Please go ahead.
Oh, sorry.
No, never mind.
So maybe this is maybe overly optimistic, or but I think that I do think that we're entering occupational medicine's golden age. I think that we're seeing a convergence of aging workforces, emerging hazards, things like artificial intelligence, these new sort of like invisible disabilities that are getting more visibility. I think will create unprecedented demand for physicians who understand that that health happens at work, and that work is a vital sign. And I hope, yeah, I think the sky's the limit, and these conversations are really exciting, and it's an absolute privilege to be here. And thank you.
Thank you, Dr. Cameron.
Doctor Norville, a mí me gustaría hacer un pequeño comentario acerca de lo que comentó el doctor Quentin. Estoy muy a favor de lo que mencionaba. Efectivamente, debemos apuntar a que directivas nacionales busquen cambiar la realidad. Mm, por ejemplo, en la realidad peruana, donde el 75% de informalidad, eh, donde el 75% de trabajadores laboran en la informalidad, la normativa es muy bella, pero solamente está cubriendo el 25% de trabajadores. Y el 75% que está en la informalidad no es cubierto. Entonces, definitivamente hay una brecha gigantesca. Y como bien decía la ingeniera Paulette, el tema de inversión, el tema de cuánto es lo que las pequeñas empresas pueden invertir, es muy poco. Entonces, incluso hablando de formalidad, las microempresas probablemente no tienen un esquema de costos que permitan costear un servicio, porque obviamente esto es costoso. Entonces, como decía también el doctor Rajib, coincido con él también, es importante que ILO, los diferentes estados, si se siga promoviendo estas alianzas para ir haciendo cambios. Como bien decía el doctor Quentin, antes había trabajo forzado en niños, ahora ya no. Y es necesario hablar de estos temas porque ¿qué hay de toda la informalidad? La norma muy bonita, pero ¿qué hacemos en base a ello? Entonces, probablemente alianzas, y como decía mi tutor, ¿no? Porque en Perú está el tema de seguridad y salud en el trabajo. ¿Por qué lo piden? Pues por el Tratado de Libre Comercio, él nos explicaba. Entonces, para mí es estrategia. Tengo que agarrarme del mayor desarrollo en otros lugares, lo que dicta y promueve ILO, por ejemplo, y tratar de que en cada estado se vaya promoviendo más directrices, lineamientos en materia de seguridad y salud en el trabajo. Pero eso es algo complejo. Y como decía hace unos momentos, hay que ver el bosque y no solo el árbol. Y algo que me gustaba mucho de lo que decía también mi tutor, el doctor Marcos, a quien yo le tengo mucho cariño y aprecio, es que decía, En la especialidad no se forma a médicos de empresas, se forma a médicos especialistas que tienen que lograr eh, emitir su voz para visibilizar estos problemas que probablemente eh, no están siendo hablados. Por eso es que valoro mucho esta oportunidad que tenemos para hablar de estos temas. Ya, para ser breve, doctor, preguntaba sobre cómo veo el futuro de la especialidad. En Perú hay especialidad, hay especialistas y también hay personas con maestría, personas con diplomado, personas que buscan aprender de medicina ocupacional y yo creo que aquí lo que se tiene que buscar es cooperar, porque desde todos los frentes debemos de lograr unirnos para promover más la seguridad y salud en el trabajo, y no solo en el área médica, sino de forma multidisciplinaria. Me encanta que en esta charla, en este pequeño compartir, estemos dos médicos, pero también la ingeniera, porque esa es una muestra clara de lo bello de la multidisciplinariedad. O sea, tenemos que apoyarnos entre los distintos equipos, ergonomía, psicología, la parte de higiene. Entonces, yo veo el futuro de la seguridad y salud en el trabajo brillando, como decía el doctor Cameron. Eh, el cielo, el cielo es la meta, o algo así, si no traduzco mal.
Límite, límite. Gracias, doctora Carmen. El cielo es el límite.
Bueno, respondiendo la última pregunta, el futuro para la seguridad y salud ocupacional acá en Ecuador, yo lo veo que va a evolucionar. Pasará de ser un requisito legal a convertirse en un eje estratégico de sostenibilidad y competitividad, tanto en Ecuador como a nivel global. Para resumir.
Bien, muchas gracias, ingeniero Paulet. Thank you, Dr. Quentin, Dr. Rajiv, Dr. Ivan, Dr. Penny, Dr. Aliwin for being with us even over 10 p.m. It's been such a wonderful webinar because of your contribution. And thank you, Dr. Carmen, Dr. Cameron, Engineer Paulette, for sharing with us during this roundtable because it's been, I think, very, not only useful, but inspiring conversation and sharing moments with you, especially because of the challenge we are facing and the future that we want to build for all the occupational health and safety professionals. So I don't know if you would, Dr. Quentin, Dr. Rajiv, would like to give final words before we say goodbye.
Thank you, everyone. Thank you, Norville, for your organization and the huge support of Peruvian members for ICOH and occupational health in general. Thank you so much.
Thank you. Thank you, Dr. Quentin.
Well,
Thank you, Dr. Novel. You've been a great support. Really, you've taken this voluntary initiative on your as a huge responsibility, and you're doing so wonderfully well to knit together the entire scientific committee's landscape of International Commission on Occupational Health. Such a big force. You are an asset to the world. Thank you.
Thank you, Dr. Rajiv. Namaste.
Well, thank you so much. By my way, I think that it's wonderful job that you are making, Norville, because to join 4 continents in one webinar, it's very, very difficult. And it's a very good job. Congrats.
Thank you, Ali Gwen. I really appreciate your words. I don't know if it's there, Dr. Ivan or Dr. Penny. I think Dr. Penny already left. It's quite late there in South Africa. But thank you all. We would like to invite you to our next webinar, which will be held this 18th September, co-organized with Nanomaterials and Occupational Health Scientific Committee of ICOH. So you can see the information in the website of ICOH, and you all are invited for sharing and joining us. Thank you, and this recording will be published in our YouTube channel too. Thank you.
Thank you. Good night.
Good night.
Thank
Buenas
you.
noches,
Good night.
muchas gracias.
Muchas gracias a todos. Buenas noches.